This is a 74-year-old woman who presented in poor neurological grade, Huntington Hess 4 with a right hemiplegia. And on the non-contrast CT head, you can see extensive subarachnoid blood in the posterior fossa and basal cisterns with early hydrocephalus. Catheter-based angiography injecting into the left subclavian artery shows a dominant left vertebral artery which is severely tortuous, limiting intracranial access. On the intracranial view centered over the posterior inferior cerebellar artery, a small broad-necked aneurysm is apparent, incorporating the origin of the posterior inferior cerebellar artery. Because of this patient's poor neurological grade and significant medical comorbidities, she was not considered a reasonable candidate for open surgical clipping, and so the treatment strategy was partial coiling of the aneurysm, followed by more definitive treatment if the patient made a reasonable neurological recovery. In this higher magnification view on the left-hand side, you can see the broad-based posterior inferior cerebellar artery aneurysm completely incorporating the origin of the posterior inferior cerebellar artery. On the right-hand unsubtracted view, the dome of the aneurysm has been partially coiled, and the coiling is not particularly dense, but additional coils could not be delivered without compromising the origin of the posterior inferior cerebellar artery. The immediate post-coiling image on the left shows reasonable occlusion of the dome of the aneurysm and preservation of the posterior inferior cerebellar artery. And fortunately, the patient did go on to make a significant neurological recovery, and so returned 3 weeks following her initial treatment for placement of a stent into the posterior inferior cerebellar artery and additional coiling. You can see on this right-hand image a catheter in the non-dominant right vertebral artery so that retrograde catheterization of the posterior inferior cerebellar artery could be carried out. The retrograde approach was selected so that getting into the posterior inferior cerebellar artery would not require having the delivery wire and catheter herniate into the previously ruptured aneurysm. Although difficult to appreciate, an Elvis Jr. stent was placed from the right vertebral artery retrograde into the posterior inferior cerebellar artery and delivered in such a way that the proximal end of the stent was essentially flush with the left vertebral artery. That then allowed additional coiling with the immediate post-coiling result seen on the left. While it looks like there might be some coverage of the origin of the posterior inferior cerebellar artery, the stent is instrumental in preserving that outflow, and the follow-up angiographic image at 7 months in this working angle projection on the right-hand side shows preservation of the posterior inferior cerebellar artery with complete occlusion of the aneurysm as seen in this working angle view and in the Townes projection here. And this patient did clinically very well, and additional follow-up imaging was subsequently obtained with magnetic resonance angiography, which showed continued occlusion of the aneurysm.